which ones need surgery, which ones actually have a conductive loss even. Because it wouldn't be the first time that I've had someone listed for staphylotomy, and when they come to theatre, I always assess them pre-op. Hi, Bex. I've noticed that actually it's a sensorineural loss, and if I'd actually operated on them, it would have been my fault. So let's pretend we're in the clinic. Good one for you, Bex, as well, because you see them too. Becky's our advanced nurse practitioner, I think. In training. Brackets, in training. So we're going to use Prezi, which is a nice way of focusing on the thing. So let's focus on the assessment first in your clinic room. And we all know 5 ear symptoms, and which are the ones that are associated with middle ear disease? Well, hearing impairment, otorrhea, tinnitus, maybe, because if you're deaf to the outside sounds, you get pulsatile tinnitus, don't you? So it's not really the other sorts of tinnitus, it's pulsatile tinnitus with conductive loss. Very rarely otalgia, unless you get an acute infection. And dizziness is very rare with middle ear problems. Although in the late stages of cholesteatoma, it's a possibility. So already, when you're talking to your patient, you could be getting an idea whether their hearing impairment is due to a conductive loss or a sensorineural. Obviously, sensorineural, tinnitus and dizziness are much higher up the list. And we want to examine the ears. And there we go. So I wonder if we should have a little competition. We could pit Wythenshawe against, that might be a bit unfair because there are 6 people here. We could pit Wythenshawe against the MRI to see how many structures in this ear you can spot. So let's start with Khalil. What ear is it?
What can I spot, or what?
No, which ear? There are 2 ears, aren't there? Right and left. We're leaving out the middle one.
Left.
Okay. Who wants to agree with that? Okay.
We're saying right.
Yeah, you say right. Okay, so the point goes to MRI because it's a right ear, because there's the light reflex down at the bottom there with my little arrow pointing it. The temporomandibular joint is in front of the external ear canal, so the ear canal curves round the temporomandibular joint. So that's why it's always hard to see the anterior part of an eardrum, unless you're lucky enough to have a straight ear canal. So, okay, great. So MRI, you're roared into the lead there. So let's take it in turns to name structures we can see in the middle ear. So that doesn't count the handle of the malleus. It counts only structures in the middle ear. So feel free to shout them out for a point each. Come on, I'm giving you time.
Chorda tympani.
The chorda tympani, there it is. Lovely, easy chorda tympani there, very prominent. Don't often see it that prominent. Well done. And any other structures you can see in the middle ear?
Promontory.
Yeah, so the promontory's there. Well done. Great. Come on, Wythenshawe, you're falling behind. Any other structures you can see in the middle ear?
Of the IS joint.
The
Superior joint just behind there.
The incus stapedial joint is just there. That's right. In fact, you can see the long press of the incus because the joint is round the corner. You can't quite see the incus stapedial joint. You can see the long press of incus. Okay, I'll give Wythenshawe a point there. They're on the board. So 3-1 at the moment. MRI, do you want to name any other middle ear structures? That I can see them all. Okay, I won't torture you any longer. So you see this shadow here? It's obviously dark there, isn't it? That's the round window. Okay, that's the round window niche there. And then here, this dark shadow is the oval window. So you can see a hell of a lot through an eardrum. And unfortunately, this one's not got any fluid in, otherwise that would obscure your view. So, but you did pretty well. You got the corner and the long process, so that's good. And the promontories, that was really good. Okay, so you can get a nice idea. So what instruments do you have in the clinic to give you more information about the middle ear or middle ear conditions? Well, we've got tuning forks, and you all know your Rinneys and Webers. I tend not to use Rinneys very often, but sometimes it's useful. That tests if you've got bilateral hearing impairment. But when you've got unilateral hearing impairment, and the patient can point to their bad ear, you only really need to do Webers, because that will tell you if it's a conductive or sensorineural loss. What else could we use in the clinic without any investigations to tell us more about the ear? What do you want to know?
PTA?
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 PTA is unfortunately an investigation. We're having something you can do in the clinic. The Valsalva maneuver, excellent, well done. Another point to Wythenshawe. So basically, if you ask them to pinch their nose and blow while they're looking, you can see if the eardrum bulges or not. And that would tell you if you have eustachian function. In the good old days, we used to have pneumatic speculums. So you could squeeze the bulb and it would push the eardrum. So that was an alternative to tympanometry. But we don't have those anymore because we're so spoiled with all our services from audiology. Okay, and is there anything else you can think of? To be honest, I'm running out of ideas now. So let's go on to investigation. Yeah, let's come out of there. There we go. Oh, come on. And right, so here's a list of investigations. And tympanometry is quite an interesting one because that can take the place of Valsalva, can't it? Tell us. And hopefully we all know our types of tympanometry. Okay, A, B, C1 and C2. And they're all worked out on the chance of finding fluid in the middle ear. So with a type A tympanogram, you've got less than 3% chance of finding fluid in the middle ear. Okay? And with a type B tympanogram, you've got 97% chance of finding fluid in the middle ear. And with a type C2 tympanogram, you've got 70% chance of finding fluid in the middle ear. So that's why tympanometry is quite useful. Who wants to tell me what ECV is?
Ear canal volume.
Yeah, thanks. Ear canal volume. Okay, and we get that off our tympanogram, don't we? Tympanogram. And so it's very useful to have the external canal volume because it gives you a lot of information. In children, it should be about 0.6 mils, something like that. And in adults, it should be 1 or 1.3. For big heads, sometimes 1.6. But never over 2 mils, an external ear canal. So if you find that the ear canal volume is 3.6 centimeters cubed, there's something wrong. Yeah, so anyone want to tell me how you could get a 3.6 centimeter ear canal volume? But a perforation, is that? Yeah. So, okay. So with a perforation, so if you get a type B tympanogram, you then want to look at the external canal volume, because there are lots of reasons to get a type B tympanogram. I can think of 5. So, so we've just heard one from Wythenshawe. Okay, perforated ear. Anyone want to give me any other reasons?
Polycytoma.
We've not heard you yet, Michael.
Polycytoma.
I would say cholesteatoma isn't one, actually.
Tympanosclerosis.
Tympanos, yeah, it's a really stiff eardrum, I suppose, yeah.
Presence of a grommet.
Presence of a grommet is another version of a perforation, so I can't give you that one, but good effort, Tony. What's the commonest cause of a type B tympanogram that you diagnose in the children's clinic all the time? OME, yeah. So basically, if there's fluid splinting, yeah, so that's 3. Anything else?
Hemotympanum.
Yeah, sure, okay. That's also fluid in the middle ear, so I can't give you that one, Mike. So basically, I'm thinking, what happens if the audiologist can't get a seal because the guy's got a really hairy ear or something? Because remember, you have to seal to get the pressure up in externally. You have to seal it by pushing it in hard enough that it touches the sides and no air gets out. And if you can't get a seal, then you're going to have a type B tymp. So that's one reason. And the other one is if you've got an external ear obstruction like wax, that will give you a type B tymp and also a greatly reduced external canal volume. So in an adult, you might only have 0.5 centimeters cubed external canal volume because the rest of the ear canal is full of wax. So there are lots of reasons to have a type B tympanogram. So you can't assume there's fluid. And that's why the ECV is important. Because if the ECV is very large, it tells you you've got a perforation or a mastoid cavity. Or if it's so large it can't be recorded, it tells you that they can't get a seal. And if it's small, it tells you it's wax or whatever. If it's normal, then it could be OME. Okay, so tympanometry itself gives us lots of information. So doing that on little babies who can't, it's an objective, so it's an objective test, isn't it? So little babies, it's quite good to do tympanograms sometimes if you're assessing if they've got recurrent acute otitis media. Audiometry, well, we all know about audiometry, don't we? Let's see how much the team knows about audiometry. We're going to have a little comp now, and I'm going to ask you to tell me if this patient needs an MRI of the IAMs. Okay, you're all very good at ordering MRIs of IAMs, and we all know they're ordered for people with asymmetric sensory or hearing impairment. So here's, sorry about this, the audiogram has decided to have a sleep lying on its side. So apologies for that. But does this patient need an MRI or not? Okay. First person to answer correctly gets the point.
No.
No, okay. Wythenshawe, do you want to say? You say yes? Okay, we've got a yes and no, and that's from a group of ENT surgeons. So let's have the reason why we don't do an MRI. Why would you say that? Again, apologies for the fact the audiogram's on its side, but was that Michael there speaking from the MRI? Mike, why do you think we don't need an MRI scan?
Because there's a conductive loss that's shown in the right side, and they've got normal bone conduction. So it's conductive loss.
Okay, and Wythenshawe, do you want to say why they do need an MRI?
conduction on the right.
Yeah. Okay. So Avanti's pointed out that the bone conduction is unmasked. So you don't know, Mike, that the bone conduction might apply to this side. You see what I mean? And so you don't know if this is a conductive loss or a sensorineural. So I'm going to give no points to either team because you don't know. This is a bad audiogram, and the audiologist must have been a bit hungover. Remember, audiologists are humans like the rest of us. They don't always do perfect audiograms. A lot of them used to be sound technicians for rock bands and things like that. So some of them have had quite exciting careers until they settled down in audiology. So they don't always come to work in the best state of mind. So, so in other words, you can never trust an audiogram. So you're going to have to learn your symbols in audiology, right? Otherwise, you're not going to be able to make a decision on whether it's a sensorineural or a conductive loss. Okay, let's do, so that, I'm going to give no points for that one. How about this one? Feel free to answer when you've made up your mind. You're allowed to confer with your hospital, whoever's in your room. MRI or not? Are you going to tell him, Becky? Okay, guys, I'm going to give you a hand then. So again, the air conduction thresholds are nearly the same on both sides, okay? The left and the right. But the bone conduction is unmasked. Triangle in Manchester, they use triangles, don't they? Is an unmasked symbol. And therefore, it could be, but this is the best hearing, isn't it, by the bone conduction. So it could be one ear is conductive and the other ear could be sensorineural. You just don't know until you mask the audiogram, okay? So this is, so an essential thing is you use audiograms all the time in your clinic. So it's disturbing for me to realize that you don't know how to read an audiogram, yeah? Imagine making decisions for people. Imagine if you said, oh yeah, this is bilateral conductive. And of course, one ear was sensorineural and the other ear was conductive. One of them's got to be conductive because otherwise you wouldn't have a bone conduction up here. But if you operate on the worst one, which might be the sensorineural, then it becomes a dead ear that you've operated on. Yeah, it's always your fault once you've operated on it. So again, this isn't masking, and you need masking to determine which ear is responsible for that reasonable bone conduction. Okay, let's try this one. Oh God, no, that's too difficult. I'm feeling sorry for you. Let's try this one. Now you've got, someone's got to say something here.
Like unilateral sensorineural, so I would.
Unilateral?
There's a dip at 4K.
Yeah, so well done, Cleo. So the 4K dip, and you're guessing it's unilateral because you know, with all your experience, that conductive losses tend to be in the low frequencies and sensorineural losses tend to be in the high frequencies. Yeah, and therefore it's most likely to be a sensorineural, but there's no masking. But you're right, most losses tend to be, but it's not a unilateral because even on the left side, it obviously crosses a right. On the left side, there's still the same picture, but it's only down to 40 dB. So this is what we call an asymmetric sensorineural. Yeah, unilateral if one's normal and the other's down, and asymmetric if one's worse than the other. And you've got to be worse than the other by the repeatability of any single point. So if I did an audiogram today and then you repeated it an hour later, I would expect that this point here would be within 10 dB of my original point. Okay, so that's the repeatability of a single point. So where we say if it's 15 dB distance or over, then you can take that as asymmetry. So of course the difference here is 35 dB. So that's definitely asymmetry. Therefore that deserves an MRI. Well done, Khalil. Withenshaw hauling it back there. Up to 3-2 now. Okay, what about this one? Glad the audiogram stayed upright this time. Is the top graph the left or the right ear?
Left.
Left.
Pardon? Say it again.
Left.
Did you say left? It's
I
the
say
right.
left.
Cross is the right.
This is the right hand side.
Yeah. So Withenshaw at that point, it's 3-all now. So come on, who thinks this patient needs an MRI of their IAMs? Weird, isn't it, when you put on the spot? And to think you guys are ordering MRI IAMs all the time.
I don't think so, because it's similar on both ears, but if there's anything, there's conduction.
So that's why you guys have to learn the symbols, what these symbols mean. Otherwise, you can't work it out. So look, if you look at, as Khalil says, X's are right, circles are left. That's air conduction. So 40 is to 45, 35 is to 50, 50 is to nearly 60, say, and there. So that they're similar. So maybe the left one is just slightly worse in air conduction than the right. But what do these symbols mean? The box brackets.
Mask.
Mask.
So that's masking, and masking on the left means you have it that way around, and masking on the right means you have it that way around. So on the left, when they mask the sound, I haven't put unmasked in at all. But unmasked would be mirroring this one probably. But on the left, when you mask the left, the hearing threshold improves right up to 20, 25, 30, 35, and 25, yeah? So the masking, so all of a sudden now this becomes a conductive loss where you didn't know before you did the bone conduction. And when you do the same on the right side, the masked bone conduction mirrors the air conduction. So does this patient need an MRI of the IAMs? First to answer gets a point.
No.
A no from Khalil. Okay, what about central?
Yes.
Well done, Michael. Because look, this here is a sensorineural loss, isn't it? The bone conduction mirrors the air conduction, and it's an average of 55 dB, say, for all those points. And here, this is a conductive loss. So even though the air conduction mirrors that, the bone conduction is much better. So this poor patient's got a sensorineural on the right and a conductive on the left. So who's to say they don't have an acoustic neuroma on the right? So well done, Mike. MRI soared ahead 4-3. Okay, so this one definitely needs an MRI. How about this one? Remember, it's really important to understand what the symbols mean. That's the clue with audiology. Does this patient need an MRI IAM? Remember, you're going to... Pardon?
We're saying yes.
A yes from everyone? Okay, what does Withenshaw say? Okay, I agree with you. Because which ear do you think is the bad one? It's the left. I don't know why they put a triangle there. Because in some nomenclature, the triangle does mean the other side. So this is the right ear. Yeah. And this is unmasked. When it's just a greater than sign, it's unmasked bone conduction. That's another, again, some symbols vary around the world, so you just have to know them all. So that's unmasked bone, and that mirrors the right threshold. So, and on the left side, they've not bothered to put the left air conduction, but instead they mask the bone on the left. What do these little arrows mean coming down from the symbols? All these arrows coming down. Well, I'll tell you. It means...
No recordable response.
Yes, that's it. You've turned your audiometer up as loud as it can go, and it can't go up any louder, and they're still not responding. So all you know is that the real threshold is somewhere below that. So you just put an arrow underneath, yeah? So you get that on, you'll be seeing them on all your audiograms now. You'll be noticing them, hopefully. So basically that means they can't record when they mask. I don't know quite what they've done with the symbols here, but when they mask the other side, you can't see any threshold. It's always below the limit of the audiometer. And even they've turned the air conduction up to 110 and they can't get any response. So they've got a dead ear. This patient's got a dead ear effectively, haven't they? And they definitely need an MRI to determine whether it's a retrocochlear cause or something else. So I think what this little exercise has shown is that you guys don't know how to read an audiogram. Yeah? And you're listing people for surgery, and you can get into trouble because you can basically list someone who's already got a dead ear. This is you're going to be able to read this one by the end, okay? I promise you. So let's do a little bit of basics before we go on to anything else. How do you do? How do you know about the symbols? Well, I disagree. We don't use this thing in Manchester. The triangle for us is unmasked bone, but in the rest of the world, it's a greater or less than sign. And basically, we do use unmasked and left and right. Okay. Do you know, I made a terrible mistake on the last one. Yeah, I got my left and right mixed up, didn't I? Sorry. That one, of course, is the right and that's the left. So apologies for that. So basically, when it's masked, it's a square bracket, and if it's unmasked, it's that. Or in Manchester, they tend to use this for unmasked, as it can apply to both sides, so you don't know which side it applies to. So whenever you see a triangle, you know your bone conduction is unmasked. I would assume, and they only seem to use crosses and circles for air conduction in Manchester. Okay, so how do you mask? How do you mask a patient? Has anyone ever seen a patient being masked? No. All right. There's oh God, this has got to be worth at least 3 points if someone can tell me how you mask a patient.
Play additional sounds to distract them.
Yeah, so how do you play the additional sounds, Tony?
On the system.
Yeah, but what do you play them through? The bone conduction, the air conduction, what? Okay, so we've reached the limit of your knowledge. There's okay, so I'll just show you how you do masking. So what happens is you want to, as Tony says, you want to distract the non-test ear, because when the it might be easier actually to start with. Let's start with masking rules. Okay. So rule 1 of masking. Tells you when you need to mask. If the difference between the unmasked air conduction is on each side is greater than 40 dB, you need to mask the bone conduction. So let's have a look at an example of that. Okay, there. The air conduction on this side is the same as the air conduction on that side. No, it isn't. It's 40 decibels worse than the air conduction on that side. So you need to mask the bone conduction. All right. So that's rule 1 of masking, because the air conduction on this side is much worse than the air conduction on that side by 40 dB or more. Okay. Sounds like a nuisance why we have to learn audiology, doesn't it? But the trouble is, if the audiologist makes a mess of their audiogram, right, you'll be making a decision to operate on a patient based on them. And if it all goes wrong and the patient says, well, actually, I'm taking you to court because you could tell from my audiogram that I could never have achieved what you said I could with the operation, it'll be you that goes to court, not the audiologist. Yeah. So even they can make as many mistakes as they want, as long as they're not putting anyone in for surgery, they're not doing any harm. They might obviously be able to deafen someone, I suppose, with a hearing aid, but I don't know if anyone's ever been sued for that before. So you're the guys that have to go to court. So that's why you have to learn some audiology. Okay, rule 2. The difference between the unmasked bone and the air conduction is greater than 10 dB. Okay, so let's give you an example of that. Let's try that one. Okay, there's the unmasked bone, and there's the air conduction. So you can't tell which ear this applies to. It might be both ears, in which case it's got bilateral conductive, yeah? It might be that the one's conductive one sense neural, or the other's conductive in the other sense neural. So you have to mask the bone to find out which ear it applies to. Okay. And then the final one, rule of masking, is okay, when you're not using rule 1, if the bone conduction on one side is 40 decibels better than the contralateral air conduction, it could be that when you put your air conduction threshold in, because it's 40 decibels greater than the bone conduction on the other side, it could be that the other side cochlear's heard it. Because we all know that the crosshead masking effect of sound. So in other words, if someone talks to me at 70 decibels on the right, my left ear can hear it at 30 decibels. Because the head only masks sound by 40 decibels. So it all sounds really boring, this, but it's really important when you're listing a patient for surgery. Because, you know, you wouldn't want to have someone with a sensory loss going for middle ear surgery without you being aware of it. So you can definitely put it in on the consent form and make sure that you don't get done for causing them to have a loss. So in this case, you need to mask the air conduction. Okay, so when you mask bone conduction, that means you're using your bone conductor. Doesn't matter which side it's on because it's vibrating the whole skull, and the masking sound has to be an air conduction sound in the non-test ear. All right, so let's teach you how to do that. So what you do is, so here's the test ear, and it's basically hearing at 60 dB. Okay, but the non-test ear, bone conduction, or even air conduction, is at 20 dB. So there's a 40 decibel gap. So it could be that when you turn the sound up to 60, the non-test ear is hearing it because you're vibrating the skull. So how do you find out? So you've got to put a sound into the non-test ear, as Toby said, and then retest the threshold on your test ear. So you play white noise into the non-test ear at 20 dB, and you get a threshold on the other side of 60 dB. That's still 40 dB difference. So perhaps it's just crosshead sound again. So what about if we turn the masking sound up by 5 dB? So the white noise in the non-test ear, you turned up the volume, and then you retest the patient's hearing in their test ear again. And if that goes up by 5 dB, that means that it was the non-test ear hearing it after all, because once you reach that 40 dB difference, the patient hears it because it was their non-test ear that was hearing it above the white noise. Incredibly boring this, but it's really, really important to understand what's going on. And then if you turn it up to 30 dB, then the non-test ears masking white noise in their air conduction headphone, and then retest the patient again, it goes up again by 5 dB. So again, they don't hear it until it goes above the masking sound, 40 dB above the masking sound. So you're getting a slope. So clearly, it's the non-test ear that's hearing it, because every time you turn the masking noise up, just like when you go to a nightclub, you have to scream at each other. You haven't gone deaf. It's just that the masking noise of the DJ has gone up so loud, you've got to speak above it. So as you turn the masking sound up, so the threshold on the other ear goes up, which proves that it's the non-test ear that's hearing it. Yeah. And then eventually you turn it up to 35 and it goes up by 5 again. But then eventually you turn it up by another 5, it doesn't go up. You turn it up by another 5, it doesn't go up. Turn it up again, it doesn't go up. So how can it not be going up? Because the difference now between 75 and 50 is only 25 dB. So the crosshead masking is 40 dB. So how could they be hearing that? They can't be hearing it with the non-test ear. It actually must be the test ear that's hearing it. You understand? Because it's finally, you've reached a threshold where the test ear, oh, that's good, can actually hear it. So when you get a plateau, it's called, that means your test ear is actually hearing it. Eventually, if you keep turning the masking thing up, when it's at 70 dB, the masking noise starts to be heard by the test ear, because it's so loud now, the masking noise, it's crossing to the other side, and it's like the test ear is now in the nightclub. So it can't hear so well because of the background noise, and so it starts to rise again. That's called over masking, when the test ear can start to hear the sound put into the non-test ear. Right, is that as clear as mud or not? Do you kind of get it, or do you want me to go over it again or something? Or what do you think, MRI? Do you get it? All right, shall I go over it again? you know the best way to understand it is to try and teach one of your colleagues how to mask. Because once you try and teach someone, you've got to understand it to be able to teach them, don't you? So not everyone's here today, so make a point of trying to tell a colleague how to mask an ear. You get it? Because that's the way that you'll really learn. And I was lucky because I happened to go to Glasgow Royal Infirmary, where Professor Browning had the MRC, Institute of Hearing Research, and we had lots of academic audiologists there, as well as otologists. And basically, we had to learn all this stuff. In fact, they used to tell the audiologist to send a masking chart round with the audiogram so they could make sure they'd masked it properly. Because we didn't trust our audiologists, because you often found they made mistakes. And if you're going to base your surgery on a mistaken audiogram, it could be really bad news. So that's how I know about masking. And basically, you're looking for a plateau. You only need 3 points for a plateau. This is a bit excessive that it's so many points. 3 points is enough to confirm that that is the level of the test ear. And then you have the slope each side for under and over masking. Okay, I won't ladle a point, but now you guys should understand the rules of masking. Now let's go back to your audiology. So you already know why this guy may or may not need an MRI of the eye end. What he needs to do first is to go back to audiology and you say, please, can you mask the bone conduction threshold on the crosses? Yeah. And basically, when they do that, if the bone conduction is down here, then it's a sensorineural loss. If the bone conduction is up here, then it's a conductive loss. So that will answer the question about whether you need an MRI or not. So this one, does someone want to tell me what the right answer is here? Yeah, so basically you're going to send this one back and say, oi, you need to mask this. I can't tell which ear is the bad one or if they're both the same. And you might get the square brackets where the triangles were on both sides if it's symmetrical bilateral conductive loss. Or you might get the square brackets lower down if one of them is sensorineural. Yeah, big difference. In that case, they would need an MRI. Ah, now you're going to be able to answer this question. Okay. So here's the air conduction, isn't it? The circles and the air conduction on the left, yeah. All right. And this little cedilla here, the downward pointing thing, is an international sign for unmasked bone conduction. I know it said greater than or less than, but basically you can do it like that as well. I think this means that you haven't said which side you put your bone conductor on. I think if you put the greater than or less than, you can say which side you put it on. It shouldn't make a difference with unmasked, but anyway. So that's the unmasked bone conduction. So there's a gap between the right and the left thresholds and the unmasked bone conduction. So both sides have a hearing loss. One is only mild and one's moderate. So you need to mask, because rule 2, if the bone conduction is 10 dB better than the air conduction, you need to mask the bone conduction. So you mask the bone conduction, and there is the bone conduction for the right side. Okay. And here's the bone conduction for the left side. There it is. So the right side is a conductive loss, but it's only a small conductive loss there. And the left side is a much larger conductive loss with the Carhart effect. You see, you go worse down to 2000, coming back up. So the bone conduction goes down here to 35 at 2 kilohertz, well below the bone conduction on the other side, which is at 5 dB. So does that mean not only does the patient have a left conductive loss, but do they have a sensorineural as well? That's going to be for 2 points. I've already told you the answer. You might not have heard me say it. It's not masking, it's Carhart is the answer, yeah? So what's the Carhart notch? And what does it mean? Right. So we all know the Carhart notch is at 2 kilohertz, that the bone conduction seems to go lower at 2 kilohertz and come back up. And why is that? So let's explore that. You really need to understand these things if you're going to do otology or list anyone for an ear operation. So here's an interesting thing. This is a patient who had a stapedotomy in the left ear, and basically, or is it the right ear? I can't remember. Anyway, so there's the air conduction pre-op. Sorry about the on its side again. And there's the mask bone conduction, his left ear. So you've got a nice big air bone gap and it's masked. And post-op, there's their threshold. So notice the bone conduction here went down to 40 dB, okay, pre-op. But the bone conduction got better after their stapedotomy to 25 dB. So how can that be? How can bone conduction improve after middle ear surgery? Doesn't make sense, because isn't bone conduction meant to be your inner ear, your cochlear hearing? Anyone want to explain it?
Isn't Carhart's notch to do with artifact from sort of natural resonance of the acicular chain?
It is, I don't know if it's artifact, but it is due to not resonance of the acicular chain. Let me explain. When you put a bone conductor headband on, yeah, the bone conduction thing they use for doing your bone conduction in a hearing test, it vibrates your skull and vibrates directly your cochlea. Okay, but a far more efficient way of hearing, as of course every Rinne test tells you, is you can hear the tuning fork better when they hold it in front of your ear hole and the sound vibrates your eardrum, yeah? So basically what happens is when you vibrate the skull, it also vibrates the air in the external ear canal. So not only do they hear direct vibrations to the cochlea, but you're actually vibrating air in the external ear canal, and that goes through the eardrum, through the ossicles to the cochlea. And because your resonant frequency of the cochlea is at about 2 kilohertz, you get the maximal effect at 2 kilohertz. So you basically, when you've got a otosclerosis, for example, and there's no middle ear conduction of sound, or very little, that's why they're so deaf, you don't get that component of the bone conduction, which is really air conduction, because it's that vibrating of the air in the external ear canal, which was transmitted through the eardrum and the ossicles to the inner ear, doesn't apply anymore, and you're only getting vibration of the skull, which vibrates the cochlea directly. So you seem to be deafer, especially at 2 kilohertz, where the resonant frequency is. Okay, and once you've made the middle ear work again, and the eardrum's vibrating nicely, and the new piston is moving in and out of the oval window without any bother at all, then all of a sudden, when you do the bone conduction, you get that component of vibration of air in the external ear canal again, and you get that air conduction, and then all of a sudden, the bone conduction threshold seems to get better. Do you get it? Yeah? I know it's a bit technical, isn't it? But you have to understand it because you're going to be making decisions. So, nice thing happens when you do stapes, that the bone conduction actually is better post-op than it was pre-op. But that's because part of your bone conduction is actually air conduction. And you can't stop that air conduction without filling the ear with plasticine or something, you know, so you stop the air vibrating in the ear canal. Is that as clear as mud as well? Okay, right. So that's a Carhart effect. And all I would say to you is go along to your audiologists, yeah, and query a few more audiograms. If it doesn't seem right to you, yeah, just do a little bit of reading about audiology and just be more suspicious of the audiogram when you're looking at it. Audiologists make more mistakes than you do. And that's saying something. I know, I've been a junior doctor. So, okay. So that's the number one thing I really wanted to teach you today, is how to read an audiogram and maybe interpret tympanometry as well. Okay, so we've decided that our patient, that last patient, really did have otosclerosis because when we did their assessment, oh, not that one, this one, we did their tympanometry was type A, the ECV was normal, the audiometry showed 60 dB conductive loss, with normal hearing on the other side. What would their stapedial reflexes be like?
Absent.
Yeah, because obviously the stapes is stuck. But it's actually, if they had a 60 dB threshold, it's quite hard to get a stapedial reflex anyway. Because you've got to get a stapedial reflex, you've got to have them sound so loud that the ear, the little muscles in the ear, whose job is to protect the cochlea, want to go into spasm to deafen you, basically. So when you go into that nightclub and it's booming, your little stapedius muscle and your tensor tympani muscle both contract to stiffen the acicular chain and protect your cochlea from getting such loud noise. The trouble is, if you don't leave that environment every 40 minutes or so, yeah, the muscles get tired and then they relax and then you get the noise damage. So that's why when you go to a nightclub, you should drink a lot. You don't have to drink alcohol, for those who aren't allowed to drink alcohol, so that you go to the toilet every 40 minutes to give yourself a little rest from the noise and let your little muscles relax for a while. So the stapedial reflex, and to get the stapedial reflex to happen, you've got to make a noise that's 70 dB above threshold. Okay? So it's really good for testing someone with a small conductive loss, like 20 or 30 dB, to see if their stapes moves, because you could make a noise at 90 dB or 100 dB, and that's 70 dB above their threshold. And if they should have a stapedial reflex. If they don't, then that's suspicious they've got early otosclerosis. So it's a good test. What about a CT scan? CT scan, what does that show you about the middle ear? Why is it better than an MRI scan? Anyone want to hazard a guess?
Better for imaging bone.
Yeah, because the middle ear is really bone, isn't it? It's ossicles, it's, you know, tympanic ring, promontory, and all the rest of it. And if you an MRI scan just misses all of these essential structures, so you just don't see anything useful. So maybe a bit of fluid, and maybe if you do a DWI, it might tell you if you've got some cholesteatoma. But all it does is say yes cholesteatoma and no cholesteatoma. It doesn't actually tell you anything about the middle ear. So it's a rubbish investigation for middle ear problems. So we often see people sent to me for staphydotomy, and I noticed they've had an MRI of IAMs. So probably the doctor who did ask for the audiogram didn't understand the audiogram, saw a unilateral loss, and maybe send them for an MRI IAMs, and then eventually realizes, oh yeah, right, and then sends them for a CT. So you can save the NHS a bit of money by leaving the MR out, because you now can do audiology. So let's get back to our options. So you've got the patient in front of you. They've got a 60, 70 dB conductive, and you're convinced it's otosclerosis because the radiologist who looked at your CT of temporal bones told you they can see otosclerosis on both sides, even though one side's normal hearing. The stapedial reflexes are absent on both sides, interestingly, and your your audiogram's properly masked. And as I said, you've got normal ECV and type A tympanogram. So that sounds pretty like otosclerosis to me. Obviously, you can see their normal eardrum. So how are you going to work out? Well, like everything in life, there are lots of options. And in this sort of case, with middle ear problems, hearing problems, you've got an air conduction aid, a bone conduction aid, or surgery. So how do you work out which is the best one for the patient? Well, you want the advantages and disadvantages, maybe, of air conduction aids. They're very safe to put in, aren't they? You don't get a dead ear from having an air conduction aid. And they're reversible. If you take it out, it's just as if you never had one. What's the downside? Well, people don't like the cosmetic thing. You know, they sometimes cause earache if they're shoving the end far into your ear canal. Then the deafer you are, the tighter the seal you have to get. So it tends to be less comfortable. It doesn't stop your otosclerosis getting worse, does it? Because it's not influencing that at all. And there's something an audiologist will tell you, that to aid a conductive loss takes twice the power of the hearing aid than aiding a sensorineural loss. So to drive the system, the decibels have to be higher for you able to hear it with a conductive loss. You've got to understand physics to understand why. And I must admit, an audiologist did explain it to me once, and 5 minutes later I'd forgotten. So I'm not going to try and explain it to you. But suffice to say that audiologists don't like aiding conductive loss because it's hard for them to aid them. And it's quite easy to reach the limit of what a hearing aid can do because it has to be twice the power. So that's why we get on well with audiology, because we like conductive losses. As surgeons, we can operate on them, try and cure them. And audiologists like sensorineural losses because they're easy to aid. So we're a natural partnership. What about bone conduction? Well, it requires less power than the air conduction aid because you're vibrating the skull. So you don't have to try and get the sound through the stiff vesicular chain. It's remote from the ear. So that's good. So if you have a discharging mastoid cavity and a large conductive loss, you don't want to stick it in the ear hearing aid. So a bone conduction one's really good from that point of view. But it's, again, cosmetic. You've got a titanium bolt coming out through your skin. Doesn't stop the disease progression. And you can get site infection where the bolt comes through the skin. What about surgery? Well, surgery can offer the patient a cure from their otosclerosis. Yeah, really good. And basically, sounds fantastic. And it's obviously comfortable. Once you've had your operation, it heals up. there's nothing in your ear or nothing that you can feel, and cosmetically it's very acceptable. Unfortunately, surgery comes with anesthetic risks and a risk of a dead ear. And the patient has to understand this. And I've always told patients throughout my career, it's not my decision, because they often say, well, what would you do, doc? And I say, well, it's not my decision, it's your ear, and it basically is you that's taking the risk. And I always used to quote a 2% dead ear rate. I thought that was a safe thing to quote, and no one can accuse me of playing it down. And it's irreversible. So once you're cured, you're cured. But if you get a dead ear, it's a dead ear forever. So I'm sure that some of you make decisions and list people for staphotomies already. There are quite a few senior registrars here and all that, SPRs, sorry. And so you've got to take lots of things into account, don't you? You've got to take the success rate of the operation. So I quoted 2% dead ear rate, I thought was safe. And I actually audit my own ears. So I know what my success rate is. How many of you, when you list someone for a laryngoplasty, quote 80% take rate on the graph? Yeah? That's the nationally accepted take rate, isn't it? But from my experience in Glasgow, the take rate went from 92% down to 50%. So are you being fair to the patient if you say 80%, or are you just basically, well, I suppose in the modern NHS, because you don't own the patients and they can be farmed out to anyone, probably saying 80% is okay. But if you're seeing the patient and you're going to operate on the patient, you really need to know your take rate so that you can quote your take rate to the patient. Much better to be honest. Patients amazingly accept. You know, I've been telling people I can deaden their ears for years and they still come for surgery. You know? Sometimes I think maybe they should run away screaming, but they don't. So you've got to be honest and don't just quote somebody else's rate and tell the patient that that's their chance, you know. The other thing you've got to take into account is whether the patient can cope with the operation, a lot of anesthetic concerns, and so therefore you might want to do the operation under local instead of general. That's a different level of expertise, but there are advantages to it as well. And if you're damaging the patient by making them dizzy, or your piston you put in is too long, the patient goes dizzy and gets nystagmus right there and then, right in front of you. So you can just take the piston out, shorten it by 1/4 of a millimeter, and pop it back in again. Then they don't get any nystagmus anymore. Wonderful. So that's why I like doing stapes under local, because it's safe for the patient. Because otherwise, when the patient wakes up after a GA, if they have terrible nystagmus, you've got to worry, don't you? Oh God, is it too long a piston? Is it pushing into the staphotomy? And then you might have to put them to sleep, take them back to theatre straight away, take it out, yeah, which is a big hassle. So that's another advantage. And the other thing is, when you're doing a staphotomy, the way I do it, I put a little vein graft over it, I think you saw in the video, so I can't see the hole anymore. So I put the piston down onto the vein, and I want to make sure it's in the hole. So one way is to just bend it a bit to see if it's engaging the edge of the hole. The other way is if the patient's under local, you can put the eardrum back down, you can say, Mike, can you hear me now? And the patient goes, oh yeah, that's really loud, you know. And then you know it's in position because they're talking to you straight away. So there are advantages. So you might choose between LA and GA by either the patient's unfit or that you feel it's better for the patient. You've got to choose your patients carefully. Anyone who's anxious or anything like that, it could be a real trial for both of you. And of course, patient preference. You know, if you mention LA to some patients, they run away screaming. Or if you mention surgery to some patients, they do the same thing. So the patient might want a hearing aid, or they might definitely not want a hearing aid. I've done bilateral stapedectomy, not at the same time, obviously, on a GP, a young lady GP, and she only had 30 dB conducting. And I said, oh, I think you ought to have a hearing aid first, because, you know, I don't want to give you a dead ear when your hearing threshold 30 dB. And she said, I'm absolutely not having a hearing. And I had to do a stay piece, and then I had to do her other side. Anyway, fortunately, she's okay. So there's a lot of deciding to do there. And if you're uncertain, I would always send the patient for a trial of an air conduction hearing aid in otosclerosis, just so that they can see what it's like. Because if they actually like it, then you've saved them the bother of having to risk, even if it's only 2%, having to risk getting a dead ear. But there's one time when there would be no point doing that. And that is, let's go back to our audiograms again, back to number 1. Let's say this was a conductive loss, okay? And there's a normal other ear. If you put a hearing aid in this ear, what's going to happen? Well, you've got your crosshead masking is only 40 decibels. So 40 takes you to 1, 2, 3, 4, takes you down to 25 dB. But look there, the threshold is 10 dB. So the hearing aid is going to be heard by the better ear before the worse ear. You get it? So there's no point putting a hearing aid in this ear, an air conduction aid in. You either put a bone conduction aid in, or you just do a stapedidotomy, because this ear here is effectively not hearing anything. If I whisper in this ear, they hear it in this ear. If I whisper in this ear, they can't hear it. As soon as I raise my voice a bit, this ear hears it before this ear, because it's the crosshead masking is only 40 dB, and therefore this ear will hear it. The non-test ear will hear it. Do you get it? So this is effectively a dead ear because it's useless to the patient. There's such a big conductive loss that they won't hear anything through that ear. So a hearing aid doesn't work. So that's another thing quite often. I find people have been given hearing aids when you can tell it wouldn't have worked. So this is one time when you wouldn't want to offer them. So with this sort of patient, they would only really be required to try a bone conduction headband or go for surgery. Okay, but I'm quite upbeat with these patients. I tell them they've got nothing to lose because they're not using this ear anyway. So either the operation's going to work or they're going to be the same. So it's not so bad. The only air conduction aid you would use on that ear would be a cross aid, wouldn't it? That would work better, where you Bluetooth the sound from the bad side to the good side, and you hear everything through your good ear, and it gives you a bit of stereo. Okay, so it's quite complicated, otology. So that's the thing you guys are going to be doing. I don't assume you're going to be doing lots of surgery, but as you get more mature, then you start to have to do the treatments. Well, you're already doing OME treatments. I hope you're doing laryngoplasties. In our day, of course, it was easier. We had lots more surgery to do. When I was ST 2 in ENT, I did 330 children's operations. In my first year, I did 3 laryngoplasties, 25 septoplasties, because what happened was we had 2 theatres running next to each other and 3 surgeons, a consultant, a reg, and we would call them SHOs, that's what I was then, at Gray's Inn Road. And between the 3 of us, we had to run the 2 theatres. So when the registrar wanted to learn how to do a stapedidotomy or a laryngectomy, he'd go in with a consultant, and I'd be put on the list next door to just get on with it. And I did lots and lots of surgery because the reg always wanted to be with a consultant. Then every so often the reg would suddenly look at his logbook and think, oh my God, I haven't done any numbers. So he'd kick me out of the theatre next door. I'd go in with a consultant. and then he'd start crashing through lots of basic stuff. So we did, in those days, we did a lot more. So it's harder for you guys because there's a consultant with every list now, and all the nurses, they all whinge, don't they, if a junior's doing the, oh God, we're going to overrun, you know, and all this. They're always giving the consultant stick because they want to go home early. So it's tough. And I don't know what the answer is, but I do know one thing, that if you're happy just to go there and watch, that's all you're going to do. So you've got to be a little bit pushy. Might be harder for some people than others to be pushy, might be against your personality. But what you've got to do is, when you watch, learn exactly how he does the op. Even a grommet, just learn how he does it. And then once you're happy that you know the names of the instruments, you know, for tonsillectomy or whatever, you know everything, you know exactly what he would do before he does it, then put on some gloves before he puts them on. And then sit down and put the towel on the patient, towel them up. Don't ask him, just do it. And then sit down. And then when he comes in with his gloves on and sees that you're already there and everything's toweled up, and you've done the WHO check and all that sort of thing, say, yeah, I've seen this a few times now. Do you mind watching me while I go through it? And then that's the way to do it. You've got to push yourselves. You've got to basically push the consultant out of the way. Do it, but by being fast, you're proving to the nurses you're not going to slow the list down. So that's the secret. So the more shy you are, the less you'll get, and you can get quite far in ENT these days without doing much surgery, which is a bit worrying. Because when I came out of my training, I'd done 6 gastric pull-ups, 25 laryngectomies. I can't remember how many neck dissections I did. And here I am, I'm an otologist. So, you know, so basically, we were expected to do it in our day, but now you have to push yourselves to do it. So that I feel sorry for you because it's a harder situation. So how are you going to make, so I've taught you how to get in and do these things, right? These are basically all the middle ear conditions causing hearing loss, which is the answer to the title of this talk. But how are you going to make yourself better doing these, or knowing if you're any good? You might just not be that sort of guy that's ever going to be any good at doing ears. I didn't know I was any good at doing ears till that audit. Excuse me. So basically, you need to audit your results, right? And how do you audit the results? It's dead easy. Because I went to Glasgow as a junior reg, I learned a good habit of auditing my results. The good thing about ear surgery is it's an excellent medium for audit, because someone does an audiogram before the op and someone does an audiogram after the op. And they don't care if it's good, bad, or indifferent. So they're not biasing it. And you've got numerical numbers for basically your performance. So you can make sure that someone anyway, has examined the ear before and after the operation. That's one way of seeing if your take rate from laryngoplasty is any good. But so you need to record, I'm sure you do, record your logbook of your laryngoplasties. But then 3 months later, make a point of getting their notes out. Or in this case, it's all paperless now. So just look them up and see what did the doctor say when they saw them post-op. You can do that even when you moved away from here, can't you? So in my day, I had to get a box of chocolates for the secretary. I had to give her a list of my ear surgery after I left, and she'd give me a pile of notes, and I'd work my way through and fill an audit for me. But it's much, much easier for you to do that now. So you should be able to tell if you're someone who gets a good take rate in laryngoplasty. And just in case you thought it might have been a fluke that I got 92%, when I redid it here with Ensure about 10, 15 years ago, weirdly enough, my take rate was still 92%. So it's weird, isn't it? So it never changed. I thought it might have got better. I was a bit disappointed. But obviously people fail for lots of reasons. So you need to know your take rate. You want to know your complications. That's another good thing about reading the post-op letter. And you can sometimes work that out by working out their length of stay, because they should be a day case for most ear surgery. And if they stay for a few days, it usually means they're dizzy or something's happened. And we used to do with mastoids, how long did it take if they got a dry ear? And I've done lots and lots of audits while I've been at Wythenshawe over the last 30 years. And basically, when I try a new technique in ear surgery, because my ear surgery's changed over the time I've been here, this is quite a good measure, the time to a dry ear, to tell you, you know, if the surgery is going to be successful or not, or if that variation of technique is worth pursuing. So I've become, I started off doing open mastoids, then I went to closed mastoidectomy, combined approach, and then I finally ended up in small cavity mastoids. And I'm too old to be bothered to learn endoscopic mastoid, but that's the future, isn't it? But every time I changed my technique, I would compare it to the previous ones and see if I was getting better results. And so when I did small cavity mastoids, first I'd compare that to my open cavities that I'd obliterated. And I found that it took much longer to get a dry ear with a cavity that you obliterated than a cavity that you just kept small at the beginning. Obviously, sometimes you haven't got the choice. But the other thing that I've done is audit my PTA results, because they're so easy to do. Just make sure whenever you practice that every patient has an audiogram before their ear surgery and an audiogram after their ear surgery, yeah? That's pretty basic, isn't it, for good care of ears? And you can go through and record the results. So what do you record? What do you record? Look, here are some. Pre-op air conduction to post-op air conduction. Pre-op bone conduction to post-op air conduction. Pre-op bone conduction to post-op bone conduction. So does anyone want to say a preference? Which one would they do? Bit tricky, isn't it? I've obviously been to an academic otology unit where they've done lots of thought about this. So what did you say, Mike? Oh, I thought he said to me. Okay, so the air conduction before the op is what the patient's hearing, isn't it? And the air conduction after the op is what the patient's hearing. So air to air is probably what the patient is noticing. So that could be useful, maybe. But what you want is when you look at that audiogram before the op, you're looking at the patient's bone conduction. And when you say to the patient, yeah, we can operate and make your hearing better, you're hoping that air conduction, conductive loss, comes up to the pre-op bone conduction, aren't you? So this pre-op bone to post-op air is what the surgeon wants. He wants to know how much of that gap has he closed. And of course, if you did just bone conduction before and after the op, then a dead ear would count as a success, wouldn't it? Because you close the air bone gap with a dead ear. So you have to do the pre-op bone to the post-op air. That's the most important thing. And of course, bone conduction before and after the op is a measure of complications. So with any ear surgery, because especially ones involving drills, like mastoid drills, you often find that the bone conduction, the high frequencies comes down. You've given them noise-induced hearing impairment from your drill. So usually 8 kilohertz, 4 kilohertz, definitely drop. And if you're a bit cat-handed in laryngoplasty, it can also drop if you're rough. So all three are worth recording if you're interested in doing that. Yeah. So one tells you if you're a safe surgeon, one tells you if you've achieved what you wanted to achieve, and the other one tells you what the patient perceives. Oh, there's one little thing I forgot to tell you about options. When you're assessing your patient, you might want to use things like the Belfast rule of thumb and all that. Do you know all those rules? So if you've got, well, let's get back to this guy again. Sorry, it's always the guy on his side, but anyway, if you don't get this hearing threshold, let's say you get it up to 30 dB all the way along. That's a big improvement. You'd be really pleased with that. But a patient thinks you're rubbish because his other ears 10 to 20 dB. And he still thinks it's his worst ear when he comes back. So, although there is one big advantage, that because it's within 15 dB of the other side, when people speak to the patient, he'll be able to tell if they're talking on the left or the right, won't he, even if he can't see them, because it becomes a functioning ear. Remember I was telling you with this big gap between the sides, that it's a non-functioning ear here. So Belfast rule of thumb, as long as you get it to within 15 dB, the patients are usually happy. So it's an easy rule of thumb. If there's no chance of doing that, then you might actually want to reconsider whether doing your surgery is worthwhile. Obviously, if you can make it better than the other side, they really notice then, they're delighted. Okay, so what else can you do in your practice of otology? You can do just that. You can practice. And in my day, it was easier than now, because a professor hadn't put lots of little dead babies in bottles in Liverpool yet, and the government hadn't made a rule that we can't operate on bits of people without their express permission, and only in anatomy laboratories. So we used to get the pathologist in the pathology department to, it's usually the porter, to cut out the temporal bone for us and give us lots of human temporal bones. And we used to operate on temporal bones. And it was fantastic, because a temporal bone, you don't have to do any pre-op checks or any consents, and there's no one can sue you. And basically, you can make a complete mash of a temporal bone and drill through the facial nerve and the cochlea and the lateral semicircular canal and make lots of errors, but practice drilling temporal bones. So I did probably 20 temporal bones in my training. But it's really important, because you've got to be confident about what you're drilling. I feel very sorry for you guys now that you get one, or what's the Scottish temporal bone called again? Pardon?
Is it field you're thinking
No, there's one from Glasgow. Oh God, I never worked for the consultant. Pettigrew.
Oh,
Pettigrew bones, you can buy them. Yeah, they're made of plastic, but it's hard plastic, so it kind of feels a bit like bone as you're drilling it. And they cost about £200 each, I think. But I think that's probably the main thing that you can get to practice on. Yeah. So it's an artificial temporal bone, which is a shame, because sometimes when I think one of my 20 temporal bones actually had a clested tendon. So that was quite good. But you need to practice on loads of temporal bones if you can help it. Yeah. If you go on temporal bone courses, because you get human temporal bones there, drill them, drill as many as you can. Make mistakes. You want to make your mistakes on temporal bones, not on people. Because when you sit down and say, Mr. Camilleri, can I do this mastoidectomy, and you've only done one temporal bone, you're not going to be confident. And maybe if you try to do that temporal bone perfectly and not go through the lateral semicircular canal, you're not going to know quite how much leeway you've got. Do you know what I mean? So what used to happen in London was, when we drilled the temporal bone, the guy would say, okay, now do a middle fossa approach to the internal meatus. He said, have a look at the temporal bone from that side and turn it over and drill. Don't always just drill the same way all the time. Yeah. So we really got a good three-dimensional map of the temporal bone, which is essential for ear surgery. Obviously, it's really important to have a microscope, be able to manipulate the microscope. So every time you're dewaxing an ear in the clinic, you're actually practicing your microscope technique. You're practicing how to hold the instruments and how to steady your hands and how to not steady yourself from your shoulder, but to rest to rest your fingers on the edge of the ear, so that you're only using the small muscles of your hand. And that takes a lot of tremor away. If you're trying to steady yourself with a sucker from your shoulder, it makes your whole shoulder stiff if you're doing it for a long time. It's quite uncomfortable. But if you stick your fingers out, touch the side of the head, it's a really good way of steadying yourself. Or when you're holding the speculum, lean the instrument at the side of the speculum, so you take away your physiological tremor. And so lots of seeing patients in the clinic and dewaxing is actually, believe it or not, good training for stapedotomy. Yeah. So when we, in some of my research, we looked at what you need to do to be able to become a stapedotomist. And it wasn't how many stapes you've done. It was how much ear surgery you've done. So even a moringoplasty teaches you to be a good stapedotomist. Mastoid, anything, putting a grommet in, everything it teaches you to do it carefully and be able to hold your instruments in the ear without damaging the patient is going to help you be a good middle ear surgeon. Okay, and then the other thing you want to do in your career, I hope, if you're on your way to learning otology, is to learn different techniques. So people come and watch me, and I do stapes with a vein graft, and then they go to Mr. Lloyd, and he does stapes without a vein graft, and it's good. You want to see lots of different ways to do it, because one day you might drop your vein graft on the floor, and you don't want to then put it in the ear. Or staff might say to you, oh, we haven't got that drill. You've just got a perforator or something. So you want to see lots of different ways of doing an operation. Even with grommets, you want to know, why do some people use shepherd grommets? Why do some people use Shah grommets? And, you know, obviously it's about how long they stay in. So if you're putting a private grommet in, some guys like to do shepherds because they come out in 6 months so you can get to do the op again. Charge the patient. I don't do that. I use Shahs in both practice, NHS and private. But because they stay in for like 9 months to a year. So I always feel that's the patient getting their money's worth. But basically, you want to know all this sort of thing. When you're looking to do a moringoplasty, you want to know, what am I going to use? Am I going to use temporalis fascia? Am I going to use composite cartilage fascia, you know, from the tragus? Am I going to use just tragal perichondrium? Am I going to use, I don't know, dead pig fascia or whatever? They have sterile pig fascia nowadays, don't they? So you want to see which graft you're going to use and why would you use it? And you want to be able to take more than one graft, because there might be some time that you're going to take some temporalis and there's none there because people have taken it all from moringoplasties, mastoids or whatever in the past, and there's just a big gap and it's not very good condition. You might have to take something else. So that's why you learn lots of different techniques and you're never stumped. And again, same with a sacculoplasty. Do you want a natural ossicle like incus or head of malleus, or do you want an artificial one? Or do you want to use a bit of cartilage? Or do you want to use cortical bone from the skull bone? There are lots and lots of options. And you've got to learn all your options. So if you're interested, you want to learn every different type of thing. Again, mastoids. I've been through the whole journey because when I started, open mastoids were the normal thing. So I've actually old enough to live through history, but you want to decide whether, if they've just got a small attic cholesteatoma, are you going to do a combined approach and drill out the whole mastoid to get to it? Or are you just going to do a small cavity? It's so easy to do a small cavity, very quick. End-or approach, small cavity, and then you don't have to do a big drill out of the mastoid, yeah? So that's why you want to be able to do every sort of way of doing all these operations so that you can vary your technique. And then what about hearing reconstruction? A lot of people doing mastoids say, oh, I don't do a sacculoplasty at the same time. We do it a year later. You've got to think that patient's been deaf for a year after the op. And I've got quite a few cases, usually at the private hospital, that come to me having had a combined approach and the consultants never reconstructed their hearing at the same time. And they're really deaf in that ear and they say, I can't wait a whole year not to hear. And I go and do it, you know, put a piston in or something. Usually they've thrown away the incus, so I can't use that. So, you know, all these sort of things, this is what makes you a good surgeon, is to have more than one arrow in your bag. And then GA or LA we've already discussed. So hopefully, God, I've gone on, haven't I? Hopefully, I've tried to tell you all otology in one lesson, but the most important thing is, please, learn some audiology, yeah? Just learn the 3 rules of masking and basically what the symbols are, promise, sorry, I have to apologise. I'm not brilliant on symbols myself because the Manchester ones don't follow the international ones, so I get confused too. But just know, especially what your local symbols are, and understand masking, and don't think that a Carhart notch means they've got an asymmetric bone conduction. Therefore, they need an MRI IAMs. Yeah, realize that bone conduction isn't just cochlear hearing. It's got a component of air conduction as well. And therefore, you don't need to screen them for an acoustic neuroma if they've got a Carhart notch. Yeah, fantastic. It's been great to talk to you. I suppose I better say, any questions? You're probably all dashing off to work. But if anyone wants to ask me anything, see, Becky rings me up when she's got a problem. So she's learning more from me than you guys are at the moment. But if you want to ask it, Avanti rings me too, and Nega as well. And basically, if ever you want to ring me up about anything, feel free. I can always dial it up because I can get into the MFT system and I can see the audiogram and things. I can give you some advice if you want, especially if you're in the clinic on your own and your consultant's on holiday. I'm happy to take a call. Okay, so you can look me up and find out my number. Okay, cheers, MRI.
Thank you so much. Thank you.
Oh, no.
Bye.
Bye-bye. So I don't know if I can get that onto your teaching thing. That's the only problem.
The YouTube.
The Prezi one.
We've already had it, so the presentation was recorded throughout the lecture.
Oh, brilliant.
So
you've got it.
Yeah,
Oh, that's great. God, that's going to put people to sleep.